So welcome everyone. My name is Maureen Dobbins. I'm a professor in the School of Nursing at McMaster University and also the scientific director of the National Collaborating Center for Methods and Tools. And I am the co-chair of the COVID and Engaging Working Group. Lawrence Langer, who is in South Africa at the Africa Center for Evidence, is the other co-chair with me. And of the two primary activities that we oversee, one of them are the monthly webinars, giving an opportunity to share tools and resources to support evidence and decision making in COVID-19. So I'm just going to give you a really quick introduction to COVID-N for those of you who may be new with COVID-N, and I'm just welcome everyone. We're so pleased to see that you've joined the webinar today. So COVID-N is a time-limited network. We came together in response to the COVID-19 pandemic to really help two major groups. One is those who are supporting decision-making with COVID-19 to help find and use the best available scientific evidence, as well as researchers to help avoid waste by reducing duplication in rapid reviews or other syntheses that were happening, and better coordination of the syntheses that were happening in response around the world to advising on the COVID response. Currently, we have over 50 partners that are participating in COVID-N from around the world, that are the world's leading evidence synthesis, technology assessment, and guideline groups. We cover the full spectrum of the pandemic response, public health measures, clinical management, health systems arrangements, and economic and social responses, and have membership in both high income and low and middle income countries. Next slide. You can just see here the logos of many of those partners that are contributing. And if we just move to the next slide. And if you want to know more about COVID-N, there are several ways in which you can learn more. We have the link to the website here. There is a tremendous amount of information on the website that can be found there, but generally, just a few of the highlights. There's an inventory of best evidence syntheses for the main four topic areas of public health, clinical management, health systems arrangements, and then the economic and social responses. There's also information on horizon scanning for emerging issues that is happening with a global panel. And then there's a community of those that are supporting decision making. So we have this is sustained by the Engaging Work Group. So that's an online listserv. We actually have now over 300 members. We facilitate discussions on a weekly basis and have really seen some great engagement among the membership in terms of discussing issues around syntheses and methods. As well as, and we've provided a link there at JISC Mail for how you can sign up if you'd like to become involved in the listserv. And there's also a living hub of COVID-19 knowledge hubs. You can also email at thecovidend@mcmaster.ca, and you can also follow us on Twitter. And next slide, Steve. And just in terms of acknowledgements for funding for COVID-N, this has been funded in a variety of ways through the Government of Ontario through a grant to the Rapid Improvement Support and Exchange, or which is known as RISE, the National Institutes of Health Research Evidence Synthesis Program in the UK, also individual donors you can see identified there, as well as a Canadian Institutes of Health Research, CIHR grant more recently that will be funding COVID-N through to the end of 2021. So with that, I will turn it back over to you, Steve, for introductions.
Great, thanks very much, Maureen. I don't want to take up a lot of time, but thanks for joining us today. My name is Stephen Lott. I'm the Senior Lead of Communications for the McMaster Health Forum. It's my pleasure to welcome you to today's webinar, using COVID-19 targets in patient care settings as a springboard for driving global improvements in evidence and guidance ecosystem. This webinar will provide an overview of the collaborative's emerging work to use specific targets being addressed in specific settings to collaboratively drive global improvements in evidence, guidance, ecosystem cycle function, and outcomes for COVID-19 and beyond. Synergies with COVID end efforts are being cultivated. Many stakeholders are participating in both efforts. The second half of this webinar will be an open discussion about expanding the scope and value of these collaborations, hopefully in ways that will enhance your organization's activities and results. Before we begin, I wanted to note that there will be, as I mentioned, an opportunity for questions and discussion later on. In the meantime, please use the chat box to ask your questions or comments during the presentations. You should see some messages in there that I've shared already. If you have any feedback after today's event, please email us at covid-end@mcmaster.ca. We have a number of great speakers joining us today with Jerry Osheroff, Per Olav Vanbeck, and David Toby. But now, please welcome Jerry.
Thanks very much, Steve and Maureen. Welcome, everyone. Very excited to have this opportunity to chat with you today. As Steve mentioned, what we're going to be talking about is using specific COVID-19 targets in patient care settings to drive global improvements in the evidence and guidance ecosystem. So we have two goals for today. First, we're hoping that sharing with you information about the ARC evidence-based care transformation support initiatives, COVID-19 evidence to guidance to action collaborative, will tee up useful things for you in your efforts. That the things that we're going to describe that we're doing will be useful to you in your efforts. The second goal is we really want to dig deep, as Steve mentioned in the second part of this conversation, into further cultivating synergies with the COVID End initiative and COVID End partner efforts, because we're all here because we're working to try to improve this evidence and knowledge ecosystem. And there are many exciting collaborations are already underway, and we think there's terrific opportunities to build on those, and I'll be sharing some specific thoughts about what that might look like. So we look forward to the second goal of hopefully advancing those collaborations. So to help orient us to ultimately what it is that we're trying to make happen, this is really all about people. So I'd like to start with a case presentation describing MB, a 38-year-old physician who was in her usual state of good health until October of last year when she developed cough and fever, a loss of taste and smell. She was diagnosed with COVID-19, managed conservatively at home. The symptoms improved, but she continues to experience debilitating fatigue, so that 6 months after diagnosis, she's still experiencing fatigue to the level of some days she's not able to go to work, and she requires help taking care of her home. Well, cases like this, unfortunately, are quite common and are going to become even more common. And there's many other issues like this that raises questions in this particular case, like what workup for MB is appropriate? What can be done to help her manage her debilitating symptoms that she's experiencing now? How can we help her sort through benefits, risks, and costs of different management options, given the tremendous uncertainty about the evidence underpinning these issues, and what sorts of things can she expect over time? So what it is that we're going to be talking about in this session is what kinds of things can be done to broadly support patients and care teams to support their decisions and actions for many COVID clinical issues, this particular one about long COVID and many others, given the fact that the evidence to underpin these decisions and actions is very limited, as is guidance, but it's growing very rapidly. So this really sets the tone, I think, for what it is that we're talking about and what we're trying to accomplish. Well, the initiative that we're going to discuss is, as I mentioned before, the ARC Evidence-Based Care Transformation Support, or ACTS initiative, and the collaborative that I mentioned that's an outgrowth of that. So to give you some background, ARC, the U.S. Agency for Healthcare Research and Quality, initiated this ACTS project in January of 2019 to develop a stakeholder-driven roadmap for making the flow from evidence to guidance to action to data and back to evidence again more fair, that is findable, accessible, interoperable, and reusable, computable, and we'll be saying a little bit more later about what exactly we mean by computable, and useful in supporting learning health systems in achieving the quadruple aim. So those were the goals of ACTS when it began a year before the pandemic hit. And what happened over that first year is a large stakeholder community was formed, work groups were formed to produce a draft roadmap, which is essentially a path from the current state to a future state where this flow from evidence to guides to action, et cetera, would be more efficient and effective, and ARC's role in that. ARC produces things all around that cycle. So from the ARC perspective, ACTS was to help ARC do those things more efficiently and effectively in ways that coordinated with and help advance things on a much broader basis for making that ecosystem cycle work effectively. So we were about a year into this effort, defining this shared future vision and a roadmap for getting there when the pandemic hit. So we used that opportunity to form the ACTS COVID-19 Evidence to Guides to Action Collaborative just about exactly a year ago. And the goal of that collaborative was to help participants address the pandemic while at the same time accelerating progress toward defining steps toward achieving a high-functioning global evidence and guidance ecosystem cycle. And ever since it formed, because COVID-19 was forming as this was happening, of course, there has been interplay between COVID-19 and ACTS. So the ACTS stakeholder community is quite large. It has over 300 participants now from many different categories: care delivery organizations, quality organizations, health IT initiatives as well, informatics specialty societies. And as we indicate here, much of this is centered in the US because it was initiated by a US federal agency, but there is very significant international collaboration. In this last column, you can see many different organizations, a bunch of which are represented on this call today, that are active participants in this ACTS and in the collaborative. So I mentioned before this cycle whereby we go from evidence to guidance to action to data and back to evidence. And as we all know, and as what COVID and many other initiatives are wrestling with, there's a tremendous amount of redundancy and inefficiency in how this cycle works now. There's many different activities. They're not well coordinated. In the end, what should be a virtuous cycle here really isn't. The pieces don't fit well together. The gears in this metaphor don't really work well. Information just isn't flowing well. People can't get the information or tools at each one of these steps in the cycle as efficiently and as effectively as would be desirable. So this, what should be this learning health system cycle, this knowledge ecosystem cycle, as I mentioned, there hasn't really been a coordinated vision or action of how this cycle could work within and across countries. In many cases, drivers for fixing this don't exist. We don't have all the standards and infrastructure that we need to make this work. So as a net result, evidence does not flow well to guidance and so on. And this, it's not like this is a new issue. This has obviously been going on for a very long time. But the pandemic, of course, shined a very bright light on the inefficiencies and the problems with how this cycle is currently working, and created an opportunity to try to make it work better. So over the first year that we were working on this ACTS roadmap, not surprisingly, as many other organizations and initiatives have defined, we need to create a virtuous cycle of how information and tools flow from evidence to guides to action to data and so on, so that we can support learning health systems very broadly in achieving the quadruple aim: improving health, improving patient and care team experience, and reducing costs. So coming up with a vision like this wasn't necessarily anything novel. We did spend in the first months of this effort defining in very great detail what this future vision would look like from the perspective of patients and care teams and organizations and national LHS efforts. So that's essentially the ACTS future vision, just a quick thumbnail sketch of it. And the roadmap, which is still in draft form, it's in the process of being vetted and reviewed by ARC and other key organizations. The roadmap basically describes what sorts of things need to happen over the next decade to make that cycle work better. And there's 5 areas of focus or attention or of activity that would require to get to the point where by 2031 we have a mature healthcare knowledge ecosystem that supports learning health systems and delivers measurable improvements in those quadruple aim dimensions. So the five kinds of activities that this draft roadmap outlines is we need to create and use more robust governance and collaboration mechanisms that exist today. We have to refine and enhance the infrastructure, so standards and technologies that enable information to flow around that cycle. We have to enhance and develop living computable guidance and how that's implemented. And we have to evaluate each step of what we're doing so that in a learning, continuous improvement kind of way, over the next decade, we can actually achieve these ambitious goals. The roadmap is broken down into 4 different phases. The first phase is about concept demonstrations over the next 3 years, and then so on, going from there to pilots and scaling, ultimately achieving the quadruple aim, with an eye toward not waiting for a decade for good things to happen. But the core roadmap, the draft emphasizes delivering improvements in processes and outcomes in the near term. So that's sort of the ACTS roadmap. As I mentioned about a year ago, as we were sort of fleshing out all these details, is when the pandemic hit. So as a part of developing the roadmap, we formed the ACTS COVID-19 Evidence to Guidance to Action Collaborative. And the goals were to help the care delivery organizations and others that were participating in developing this roadmap to enhance evidence-based guidance and tools to support patients and care teams in the near term, not wait until sort of the roadmap execution had begun, but sort of asking the question, how can we take those collaborations and that the other work that had been done and translate that into measurable improvements in care delivery and outcomes, focusing initially on selected targets and settings in ways that would promote scaling to many other targets and organizations, and do all this in such a way that it would lay the foundation for executing this draft roadmap that the group had been working on. So the knowledge ecosystem cycle, here it is in a little bit more detail. So if we're going to make this cycle work better, what do we need to focus on? What do we need to fix or enhance? So these, not surprisingly, are the more specific steps, just an illustration of what those look like: aggregating evidence, producing guidance, creating tools. So this provides sort of the framework for understanding what the collaborative participants are doing and how we can help them do that better. Again, focusing in particular on what happens where the rubber touches the road, where patients and care teams come together to deal with issues such as I presented in the initial case. So early on in the collaborative, we created this map to say of the many different kinds of organizations: the care delivery organizations, the federal agencies, the guidance and evidence focused organizations. Sort of how do they lay out? Who is it that we're working with, and what are the kinds of things that they're trying to make happen? So this is just sort of a sampling of some of the participants and how their activities align with what's going on in the ecosystem cycle. So what we've been doing over the last year or so since this collaborative formed is having those organizations share information about what tools they're using, what strategies that they're using to address that ecosystem cycle, the individual components of it, in ways that they can come together to make that whole cycle work better. So there's a bunch of different things that we've been doing. We've been having these weekly calls. There's a website where we've been creating a repository of these approaches and tools that we're building out. And what we've started to do over the last month or so is all along we've known that there were specific care delivery organizations that were focused on improving care around specific targets. What we've done over the last month is focus much more intensively on that. So rather than just having these broad-ranging conversations about what's going on around the ecosystem and how can we make that better, we're focusing much more sharply on these specific targets that are being addressed by specific care delivery organizations, and inviting them to share in detail on these calls and on the website what their strategies are, excuse me, what they're learning, what challenges they're facing, and leveraging the collaborative to provide support to help them address those care delivery issues for patients, such as the ones I mentioned in the case at the beginning, in ways that will promote scaling to many other targets and many other care delivery organizations. So we're relatively early on in this. There's 3 targets that participants have been focusing on very intensively that are serving as the focal point for this sharing and acceleration activities. So one is anticoagulation. The University of Minnesota has been working on this target ever since, just about since the pandemic began. About a year ago, they developed a clinical decision support intervention to guide anticoagulation use in inpatients, recognizing that the evidence was very scant and it would be evolving over time, and they are doing some quite sophisticated learning health system activities or cycle activities to address that target. Another target that bubbled up as great interest to collaborative participants is long COVID, the post-acute sequelae of COVID-19. So there's an organization that supports health centers that is going to be working intensively on this target, OHSU. Another academic health center is also focused intensively on that target. So that's another one. And then severity and assessment and triage, how you can assess patient symptoms to try to understand what their course is likely to be so that triage decisions can be made accordingly. So the VA in the US and NAC as well is very interested in that target. So what we've started doing over the last several weeks is we're having what we call these deep dive sharing and collaboration calls. So the care delivery organizations are describing for each step in the cycle, because all these organizations at some level are interested in the whole entire cycle. The VA, of course, has a lot of evidence processing. The Veterans Administration in the US does work all around the cycle. Minnesota and others, as I mentioned, deal with the whole cycle as well. So they're describing for each step in that organization for that target, what major successes they've experienced so far, what sort of pressing needs they're running into, and we have conversations about how other collaborative participants can support them in their efforts, again, in ways that would be very broadly scalable to other targets and organizations. So here is just a sampling of, so when you think about this, when you think about the participants in the collaborative, there's incredible depth and breadth of expertise in all of these ecosystem cycle steps. So here's just a sampling. It's not that we're actually working with all these people today to make these things happen, but hopefully we'll be doing more of that than we are already by the time we get to the end of this call. We have teed up ideas for making that happen. So for example, when it comes to identifying studies as they relate to these targets, the Librarian Reserve Corps, which has been an active participant in the ACTS Collaborative, also an active participant in COVID End, they're doing work to improve how studies get identified. Epistemonicos, likewise a very active participant in both these initiatives, have tools that can support identification of studies. Then when it comes to synthesizing studies into living review, I'm not going to read through all these, but it sort of makes the point that in both of these entities, there's already organizations and initiatives and resources that are focusing deeply on each one of these activities. And what we're trying to do in the collaborative is to say, can we demonstrate the concept of these puzzle pieces in that diagram that I described earlier that make up the individual gears and how the gears fit together? Can we make all that work better, more efficiently and more effectively in the real world, in these care delivery organizations for these targets starting sooner rather than later? And again, several of the people from these initiatives are on this call and will help seed the discussion that we're going to be going into very shortly with some thoughts about how we might connect some of these dots. So before we get there, I just want to dive a little bit deeper on this notion of computability. A part of the reason why this cycle doesn't work as well as it should is because the information isn't as fair. The information and resources aren't as findable, accessible, interoperable, and reusable as they could be. And one of the ways that we can move things forward in that direction is by having all that information be more computable. So here's a couple slides that I borrowed with permission from Brian Alper, who sort of uses a sort of uses a mapping metaphor or model to help us understand what we're talking about. So in the olden days, when you wanted to get from here to there and you needed a map to do that, you had to use a printed document. Then I think, we all got excited when those maps, got put on CD-ROM, so you could get at the information, a much greater breadth of information more easily. And then it was very exciting when those maps became executable through varying tools. But the issue with those tools is they were all on different platforms, and you were sort of locked into the platform that you were dealing with, not unlike how many clinical decision support interventions work now. And then, the whole, there was a quantum leap forward in the kind of things that we could get done and the efficiency we could get them done when that information became computable and it became more platform independent. We could do much more sophisticated things as the information became computable. And the same thing is true for, biomedical knowledge and guides and things like that. We started out with, journal articles and periodicals and textbooks and cards that we stuck in our white coats and all sorts of things like that. Then the information became digital, which was terrific. And then ultimately executable. But again, as I mentioned a moment ago, a lot of that execution is tied to specific platforms. It's harder to share things as the information becomes more computable. That puts us in the the opportunity to make good things happen, like the analog with the computable maps. So I just want to mention that there is a project that's closely tied in with the ACTS COVID-19 Evidence to Guidance to Action Collaborative. It's another ACTS pilot supported by ARC, and it is developing requirements for tools that will make evidence and guidance more computable. In fact, we have a call coming up in the next hour of the group that's meeting weekly. Right now, we're working on use cases for the tools as a springboard to developing those requirements. So I'll skip over that. So in the tools, in order to make things computable, there are standards that are coming from things like EBM on Fire and COGA and other CPG on Fire. So we need to figure out how to use standards to make that flow more computable. And in a call earlier today with Brian from EBM on Fire and COGA, we're talking about some tools that they're developing there that could potentially be applied in the nearer term to support that cycle working better for the targets, as I've mentioned earlier, and Brian's on the call and can speak up as well. So just to sort of bring things across the finish line here, the collaborative that I mentioned is taking steps toward implementing this draft roadmap approach to achieve the future vision. We are doing things that are focused on each one of these core activities that I mentioned earlier that are laid out in the draft roadmap for achieving that future vision. So to just quickly connect some of those dots, the draft roadmap recommends an initial focus on 4 specific targets to drive the ecosystem cycle improvements: hypertension, pain management and opioid use, preventive care, and COVID-19 or pandemic response is one of those 4 targets. So all these things that we're talking about kind of amount to initial efforts to execute on this draft roadmap. The collaborative learning community is seeding the kinds of cross-stakeholder coordination efforts that are called for in the roadmap. We're laying the foundation for the enhanced ecosystem cycle infrastructure by making the best of what's available now and laying out requirements for how in the near term this information to become more computable and more interoperable. These concept demos that I described for enhanced computable evidence and guidance development and implementation, again, all this sort of amounts to initial efforts to drive progress toward that very ambitious 10-year goal. So as I mentioned, there's hundreds of individuals that have been involved over the last 2 years in developing this draft roadmap and participating in the collaborative. As we prepare to share this draft roadmap soon on a government website for public review and input and feedback, we've begun the process of getting support letters from organizations that have said, yes, we share this future vision, we help develop this roadmap, we're eager to align our strategies and investments with achieving this shared goal. We actually have 32 of these letters now from a whole bunch of different stakeholder groups. We just got one this morning from another large academic medical center. We have a bunch already. And I would point out that a bunch of these letters already have come from COVID-N participants, including one from the COVID-N Secretariat, as well as many other organizations, several of which international evidence and guidance organizations, many of which are on this call today. So to transition to the discussion that we're doing, and again, that will be seeded with some comments from some different folks. So you're on this call today, and thank you very much for being here. So presumably there's some place on this evidence ecosystem cycle where your efforts and energies are focused. So is that care delivery? Is it evidence processing? Is it guidance processing? Is it something else? And then importantly, how can the kinds of activities that I've described be helpful in advancing your efforts, and vice versa? How are the things that you're doing, might they be applied to helping move forward these other activities that I've described? So putting a sharper point on that, do you have resources or tools or expertise or networking or evidence or guidance or anything like that that can help patients with these targeted conditions? Care teams that care for these patients and caregivers, things that you can that you provide that support care delivery organizations in which this care is delivered, or things that you're doing, how might they support, how might we help them better support organizations that produce tools that help these care delivery organizations, care teams and patients. So what we'll be turning to now is what would some of these win-win-wins look like for you to provide these things that you're already doing in ways that will further accelerate progress toward achieving your objectives, in ways that will help these other sorts of things that I described that the collaborative is trying to do as a down payment on supporting these this effort to get to these broader, 10-year goal of having widespread learning health systems and realization of the quadruple aim. So with that, we're going to start the discussion now. Just a couple thoughts about some specific next steps. So hopefully this conversation will be a rich opportunity to brainstorm some specific things that we could do together, building on all the great things that are happening individually and in other collaborative efforts. A couple of folks I've asked to sort of tee up some comments, and then we'll try to open it up so that everybody can speak. Please do feel free to enter stuff in the chat. We welcome everyone to engage in these efforts, in the collaborative that I described, the sharing, figure out what some of the synergies are between what we're trying to do and what you're doing, or deepen synergies if you're already engaged. Engage in the evidence and guidance computability efforts, other efforts around making evidence and guidance computable. All these slides will be available on the COVID-N website where you signed up for this talk. There's some contact information if you want further stuff. And with that, I think what I will do is turn things over to Per Olivandovik from MAGIC, who will help kick off the discussion by sharing some thoughts about how some of the things that he's involved in with regard to evidence and guidance could become more deeply synergistic with what I've been describing. Per?
Thanks, Jerry. I was hoping there's going to be some comments in the chat box, but if not, I guess I should just get started and people could chime in.
Per, I'm sorry. One thing I forgot, I slipped the order a little bit. I think David Tovey was going to say a couple words from a COVID-N perspective as an entree into your comment. So I apologize for that. David, can you, are you able to share a few words before Per? David, we don't seem to have your audio. It looks like you're on mute. Perhaps we can cycle back for David. I'm sorry for that little glitch there, but Per, if you want to take it away.
Okay, David, jump in if you want. So hi everyone, I'm Per Vanvik, internist based in Oslo, Norway, also founder and CEO of MAGIC Evidence Ecosystem Foundation. And I'm going to talk about how we could use living evidence and guidance for COVID-19 at the global level into learning health systems like the one you've seen from Jerry in the US in this case. And as you can see from this picture, MAGIC, our nonprofit foundation, was created 10 years ago to make it easier for clinicians and patients to make well-informed decisions at a point of care. We did realize quite quickly, even though we built MAGIC app, as I'll show you in a minute, that guidelines and decision support is just a piece in the puzzle. So back in 2014, we found the need to create a bigger vision. And if you move to the next slide, or is it me moving it now? I can do it. This shows our evidence ecosystem, which we developed as a conceptual framework and now have applied in the COVID-19 pandemic. And it's been a pleasure to work with Jerry and ACTS over the past 2 years, because what you see here is just a variation of the learning health system, the loop we need to close. And what we have achieved with partners in the COVID-19 pandemic is to demonstrate how we could move from new evidence that could change practice for COVID-19 treatment, for example, into a living systematic reviews updated within a week, even with network meta-analyses. There's a great French Cochrane group doing living network meta-analyses, and then there's the McMaster University team we work with that are able to turn new evidence into fully and complete systematic reviews within a week. Then, in our case, we work with the WHO to produce living guideline recommendations. So they will meet online by week 2 and create the recommendations. And then we publish these in new formats, both through MAGIC app, which is a core platform in this evidence ecosystem, in the BMJ as rapid recommendations by week 4. Now, it's fair to say that the initiative that has, I think, achieved greatest success is the Australian Living Guidelines. They actually have weekly updates in this evidence ecosystem to produce guidance that could be used by policymakers, clinicians, and patients. And now, very recently, NICE decided to do living guidelines for COVID-19 as well, also using MAGIC app. Now, the big question today is how to get this evidence into practice and improve care. And that's where ACTS and learning health systems initiatives are important, because they actually want to take it all the way into practice. And that's where we face barriers today in the evidence synthesis and the guidance steps of this evidence ecosystem. And just to say that technology is somewhat important. So we have our MAGIC authoring and publication platform, which I think is the only platform where you can really do living guidelines at the moment. And the point here is you create and you publish and you update the content through an online platform where you immediately can disseminate the guideline recommendations in user-friendly formats. It's set up to integrate in the electronic health records as decision support. It should be easier to adapt, reuse, contextualize recommendations and plug them into different resources. And you will get tools for shared decision-making. So MAGIC app is just a platform in this evidence ecosystem that may be of use. Now, moving on, I'm just going to give you 2 examples how these guidelines look like. And they are examples of how we could produce guidance at the global level, and that could be used in healthcare systems to complete the next steps in the evidence ecosystem. So these are just screenshots. It would be much better to demonstrate them online, but there's a link in the slides you could use later. So we publish the recommendations in MAGIC app. They're all structured. You find the recommendations here on steroids first, and you click down. You could find the evidence summaries all the way down to the references. But of course, WHO also publishes PDF, and we publish in the journal, the BMJ, with infographics. So these are globally produced, trustworthy, accessible, and hopefully timely recommendations that could be plugged into the evidence ecosystem downstream. I mentioned the Australian guidelines, but just before I say that evidence synthesis and living systematic reviews are critical for making this evidence ecosystem work. And this is just an example of the huge effort done by the McMaster team to constantly update and publish new versions of this living network meta-analyses. I mentioned the Australian Living Guidelines. I think they are great. They make all their recommendations and evidence available through their portal. You click and you go into the platform to find the recommendations. They also have flow charts where, again, you can click. And all of this shows that once you have the recommendations digitally structured in the platform, you could plug them into different resources. So this is kind of a brief demonstration of how we could work together with these globally produced guidelines, also from Australia and NICE. We hope that these could be actually reused, adapted, and put into practice. So for instance, if there's a new study on anticoagulation, the University of Minnesota and that healthcare system could take those recommendations and plug them into their practice. And then AHR2 have a set of tools, something called CDS Connect, where you could create downstream decision support in the EHR. You could plug the recommendations into pathways, into protocols, and then hopefully demonstrate that this evidence ecosystem could work. So Jerry, I could see great synergies here moving forward. I think one of the key questions is whether US actors would be interested in using global guidance and work very explicitly together to make this work, because I can tell you there are lots of challenges. And now the major challenges we face are mostly on the dissemination side, the implementation side, and evaluation of impact. So that was my brief pitch for working together in the evidence ecosystem or learning health system.
Excellent. Thanks so much, Per. I mean, I appreciate you putting this question out on the table. We do have some folks from Minnesota on the call. I don't know if they're going to, if they want to speak up at this time, but certainly I think this is something that we need to pursue to see what the synergies are between the kinds of things that you were describing. David, do you want to, it looks like we have you back on video. Hopefully we have you on audio as well. Would love sort of your thoughts of, especially about synergies between the kinds of things that we're describing here, what Per described, what COVID-End is trying to accomplish, perhaps COVID-NMA, since you're involved in that as well.
Well, thank you very much. No, I mean, what I think we've seen so far is, in a way, the sort of collaborations and potential for collaborations that COVID-End was set up to do. So COVID-End came about, as some people will know, but maybe some people don't, when Jeremy Grimshaw and John Levis thought about the research response to COVID, and they could see that there was this enormous effort, large numbers of people spinning a load of plates, but in spite of that, there was a lot of a lack of coordination. Not much collaboration between different groups doing different things, and there was some variation in quality. And so they got together, produced COVID-End, and that's what COVID-End has done, has brought over 50 organizations and their representatives together to share what they are doing. And if you look across the COVID-End partners, what you see is a lot of people doing very different things in different sort of dimensions, rather exemplified by the work that Per and Jerry have talked about, people doing different things, but all somewhere within the evidence ecosystem. And in a way, COVID-End has arranged itself around the evidence ecosystem with its working groups, each taking responsibility for different areas around there. So my role in COVID-End has been initially as a chair of a group that looked at evidence synthesis. And what we did there was get together groups of people who had an interest in evidence synthesis. And what's clear is, if you look across the world, there are people doing different things really brilliantly. And what is needed, I think, and Per has really exemplified this, is to bring those people together so that people don't have to reinvent the wheel wherever they are, but they can interact, communicate, collaborate with people across the world, such as the people in Paris, such as the McMaster Group, for example, around evidence syntheses. So I could probably go on a bit longer about COVID-End, but it seems to me that what we're seeing here is an example of why COVID-End was really important, helping to bring people together who share an interest, maybe have expertise in slightly different areas around the COVID pandemic, and bringing them so they can sort of work in a sort of collaborative and complementary way. There was a question on the chat I just wanted to respond to around, has COVID-End addressed the issue of computable learning? Well, COVID-End did at one point have a digitizing group, which is currently in sort of somewhat suspended. But I think what COVID-End realized, what the digitizing group realized, was that that work was going on, led by Brian, who's on the call, as part of the COCA group. And what we realized very early on was that we didn't want to duplicate that activity. And so Brian has been involved in the groups, and maybe he would like to talk about that. But you know, really, that work is ongoing, and you know, there's no need for us, for COVID-End, to duplicate it. And part of what we're about as a sort of time-limited network of professionals is collaboration, but not duplicating, supporting the organisations like the ACTS, like MAGIC, like COCA, but not trying to duplicate what they're doing.
Excellent. Thanks, David. So we have about 13 minutes left in this webinar, and as I said in the beginning, our goal was to come away from this having identified ideally some specific opportunities how each of you can better achieve things that you're trying to make happen in ways that would move forward the kinds of things that we're trying to do in the collaborative and that are laid out in the draft ACTS roadmap. So I'd like to go back to the case that I presented at the beginning, a patient with long COVID who was experiencing adverse symptoms from that, or think about patients who are in the hospital and decisions need to be made about, you know, whether and how anticoagulation should be used for their care. Similar patients who are presenting in emergency departments or clinics, and decisions need to be made about triage for them. So let's think about real patients in real care delivery settings. And what I'd like to try to use the next 12 minutes for is to see if there aren't specific things that we can do. I mean, everyone after this webinar is going to go back to, you know, deeply intensive, great work that you're doing to move things forward. And the question that I want to put out is, are there things that you could be doing, that we could be doing together, that would better help address the needs of patients of the sort that I've described and care teams that are caring for them? So I'd love to hear anyone who has some thoughts about that. I know Camilla, you're going to sort of say a few words perhaps about epistemonicos. If you could say that in the context of this question that I just raised, or Brian, if you want to share thoughts as well. Camilla?
Sorry, Jerry, this is Steve. I wasn't able to make Camilla a presenter or panelist for some reason. I've tried to unmute her, but I'm not sure if that worked. Brian is a panelist, though.
Camilla, or do you have any audio, or you're not able to be heard? Okay, unfortunately, we don't. Brian, do you want to say a few words? You apparently have access to a mic.
Sure, thank you. And I've been involved in a number of projects you've heard through this, including the COVID Knowledge Accelerator, which is taking a whack at making this evidence ecosystem and all those gears you see in the middle of it actually coming to fruition in the sense of a common method or standard for the computable expression of all of these aspects: the evidence, the statistics, the description of the population and the interventions and the outcomes, the functional patterns for how to express these things. So we are developing the standard for computable expression, the schema, how you would put all the data in order so a computer can understand it, the terminologies that would be used. So we may have a lot of terminologies like SNOMED and RxNorm for defining the conditions and defining the medications, but for the actual communication of evidence and statistics, we do not have shared, agreed, computable terminologies for the statistics themselves, for the study designs, for the risk of bias and other certainty concepts. So we are defining code systems for these concepts. And then we are doing actual tool development. We've produced a clinical trial results reporter so you can express the trial results and have it converted to computable form. And we're developing a systematic review results reporter for something similar. And one of the active projects right now, I saw you had steroid recommendations in your living guidelines, you know, from MAGIC. And we are doing a systematic meta review where we are seeking systematic reviews of steroids for COVID. And we will extract all the data in computable form. That will allow us to determine if there are any inconsistencies across systematic reviews for this, but more importantly, for showing and moving this whole ecosystem into a functional application, is I suspect one of the things we will discover that showed itself in that MAGIC living guideline, not in so many of the other systematic reviews, is the detailed expression of patient subpopulations to assign the evidence findings to, severe versus non-severe. And if we can codify that, it will become easier for clinical decision support systems and guideline developers to keep up with changing evidence at a precise level for that clinical application. So we're working on many fronts, but happy to work with you wherever you're starting to get to that, make something tangible in computable data exchange. And coming soon, we'll have some of these tools ready for you to start using.
Excellent. Thanks, Brian. We have about 7 minutes left, and I'm wondering, you know, the forum isn't ideal, and I know we're having sort of audio problems getting people tapped in. I really would love to come away from this session at least with some sense. So I think between what Per was talking about, what Brian was talking about, I think there is opportunities to connect dots more strongly than we have already. And maybe a tangible next step is we could have a call among people who are on this call and perhaps others, a subsequent meeting for the sole purpose of digging into these synergies and cultivating them. So if people you want to enter into the chat or send email if you would be interested in participating in a subsequent deep dive to explore connecting some of these links better, some of the things that Brian talked about, some of the things that Per talked about, and others. Please enter it into the chat or send us an email if you would like to participate. That Maria, it sounds like you have a suggestion. Please jump in.
Thanks, Jerry. So I know we've talked about something similar before, but maybe picking a couple of use cases and working them all the way through the cycle, bringing together each of the different components that we've been talking about, including, for example, the ARC tools that have been part of the X project, and seeing how well they work, if there's needed, or what else is needed to really make the whole ecosystem work. I think that like one of the best next steps would be to work this through a couple of different use cases through the whole cycle.
So Maria, that's exactly what we're doing in the collaborative. That's sort of what this webinar was about. So you're talking about something beyond what we're already doing, around long COVID, around anticoagulation, around, so that's exactly what we're doing.
Well, so for example, you've mentioned several different tools in they're being developed by a few different entities. Brian mentioned a few, like I said, the ARC tools are part of this as well, and several others. And some of the potential enhancements, I think we maybe haven't talked about as much, that could make some of the work that's already out there more useful for actually realizing this cycle on a broad scale. So it's basically doing working through those use cases, but then taking it the next step. I'm not sure, and maybe I've missed something, but I think that would be really helpful to start discussing what could be enhanced or improved on with the existing tools that we're testing that can really help make this a broad scale realization.
Yes, exactly. And there was a couple slides that I showed. I went over them pretty quickly, but it was near the end of the, what it is that I shared, where I said you could envision for these individual targets taking information from the Love Epistemonikos platform and sort of feeding that into some of the mechanisms that Per described, and then feeding that into some of the things that are happening in the care delivery organization. So yes, that's exactly what it is that I'd love to do as a part of this collaborative effort. And again, we're coming down the home stretch of this call, but I think a follow-up would be to bring those folks together to explore, as you were saying, Maria, ways to connect all these systems and activities such that they're feeding into enhanced tools that are being used on the ground in these specific care delivery organizations. Yeah, so I think we'll sort of take that as a follow-up item. Pablo, I know we've had problems getting Camilla on the line. Is there a word or two that you want to say? Or Ruth, I know you had mentioned earlier about, in a chat about collaborations. Any thoughts that either of you want to share as we sort of come down the home stretch here?
Hi, so it's Ruth here. I'm not sure my camera's working, so apologies for that. So I guess what I've been trying to think about is it's about relationships. So if this cycle was being done by one person, it would be easy. If it was done by one team, it would be easy because you're literally passing the pieces of paper or the knowledge around the table and you will know each other. And I work in a far, far messier environment because I'm working outside of healthcare on a continent-wide and a global level. And so what we spend a lot of time and energy on is building relationships and just making sure that everybody around the circle knows each other and moving gradually from literally the personal relationship. So I've met you, Jerry, now I know I can email you and you will respond, that kind of simplicity, but then moving to an institutional level. So what organization do you work for, and do you know the people who are producing the guidelines, and do the guidelines people know the clinicians, and do the clinicians? So then it becomes an organizational relationship structure. And I think really what you're trying to do is establish that, is establish how do we get the institution, the bigger organs to talk to each other. But the starting point has to be the people. And I appreciate that that's what you're doing here. And I suspect, Jerry, that's what you do a lot of, is to go and talk to as many people as possible and try and introduce them to each other. So for me, there's something I'm really interested to see how it plays out and how the relationships specifically play out, because I think that's actually the glue, the secret, the key thing is the relationships.
That's a great point, Ruth. And I think taking what you said together with what I said, sort of bringing people together, and not just about interconnecting puzzle pieces or gears, but like you said, at the sort of the personal level, people are working hard to try to accomplish something, and connecting at the why level, and not just jumping right into the how or the what level. So that's a great point. So we're down to the last minute here. Again, as I said, we will follow up with those of you who attended this webinar, see who's interested in participating in a conversation about connecting the whys and connecting the hows. Any final comments? Anybody want to jump in with a last thought?
Per was being asked a question by Mary Butler about where there's been situations where you want to lead to disinvestment. And I'm sure Per can answer that for himself, but there's certainly been the experience in evidence synthesis that there are a number of, not surprisingly, there are a number of interventions that have gone off the boil as a result of changing evidence. And I suspect that's fed through to recommendations. I'll leave Per to give the examples. They're pretty obvious.
Thanks. I guess time's up, but I just want to reinforce Ruth's point. It's all about people and organizations and trust and the culture for sharing work and collaboration. And it's a lot about processes. So what we learned is that unless the actors, the organizations, explicitly agree on standards, methods, processes, and platforms, and I would say platforms is the least important part, in many ways, it won't work. It won't be efficient, and living evidence and guidance will not work. That's some of our clear learnings from everything we've done. That's what COVID tries to help, right? But we're pretty far away from the goal. And I think the question about implementation is, for me, in most countries, I would think we don't really know whether we're able to whether implement or de-implement new treatments, etc., for COVID. The evidence ecosystem is pretty much broken in many settings, I think, because we don't have this loop working.
Yeah.
I mean, you described the Australian guidelines as being remarkable, and they are remarkable. But I think the most amazing thing about them is the number of organisations, professional organisations that are involved and seem to be working together in a really collaborative way within Australia. I mean, it's just, you know, somebody in the UK, I don't think that's happening. It seems to me a really amazing thing that they're doing that.
Well, thanks everybody. We're a minute past. Really appreciate the engagement. Sort of looking forward to sort of next steps. We will reach out to everybody. We'll try to have another meeting to build on this conversation, not a webinar, but a working session to, as Ruth said, connect the people, connect the whys, the what, and the how. Please feel free to reach out to us. Like I said, the slides will be posted. Love to hear your thoughts and feedback, recommendations about next steps to continue on this journey. Have a great day, everyone. Thanks very much.
Thanks, Jerry, for a great presentation. Take care, everyone.